Okay, so good afternoon, all of you. And let me start out by thanking the organizers, Nizam and Jelena, to invite me here in an, let's say, on an intriguing subject, which I called hard choices in pediatric transplantation, not only limited to kidneys, but all organs. And so after some debate this morning with Joe, because we were teamed up as a sort of pro and con session, my position is that I will look especially at the non-medical situation, assuming that unless there is a very compelling medical contraindication to transplantation, it should always be considered for a child transplantation, but you will run into all kinds of psychosocial, ethical, and even legal hurdles. Professor Rees summed it up very nicely, I think, and I'll refer to that same sort of situation in my talk. And you should always try to find solutions for that. So I'm pro-transplantation in these difficult cases. So I think let's start out with a very simple ethical framework for pediatric transplantation that I think is familiar to all of you, and you will agree. So, as already said, what is in the child's best interest? Is the child sick enough to need a transplant? So is there a proper indication for transplantation? But also, is the child well enough to survive the procedure? Are the child and parents able to follow the medical instructions? So can you deal with non-adherence? And also, is there proper valid consent for the procedure? Is there no conflict between the different parties? So I think you could say that non-adherence or non-compliance, as it used to be called, is a very key issue that we have to look at. And of course you can say, well, if there is non-adherence, it will lead to rejection and graft loss, and you could say that is a waste of a scarce organ. And how to find out about that? So in those cases, you will need a psychological evaluation to assess the risk factors for non-adherent behavior. And of course, in pediatric patients, especially the younger ones, it mainly comes on the shoulders of the parents to see to the adherence. It's different for, let's say, adolescents. And in adolescents, in some cases, you even have a role for the psychiatrist. So non-adherence, you could say that you can tick a list of these. You should know the general situation and the motivation for the transplant. Why do we want to transplant? Is there a history in the patient or in the family of non-adherence with medication and appointments? Is there parental psychiatric events or even in the patient himself? The whole situation in the family, parental supervision, family conflict, poor communication within the family, the social, financial situation of the family, and even between the parents and the medical team there can be strained relations that become a very different hurdle. Now I want to provoke you a little bit by presenting some cases. Originally I wanted to discuss it with the whole audience, but now I'll discuss it with Joe because we had not, let's say, decided before. So these are the cases that I want to present to you, and I'll tell you what the solutions are, and then you can even tell me in the discussion if you agree with that. So this one is about a dysfunctional family. A boy of 5 years is diagnosed with progressive cardiac condition, needing ultimately a heart transplant. And of course the social worker discusses this with the parents and makes a home visit. And her conclusion was, this is a severely dysfunctional family, lack of social support all around, suspected parental drug abuse, and there is a serious risk of non-adherence for this child once having a transplant. So what can you do? And here a number of considerations that you have to look at. The social worker and the psychologist say, well, there is a high risk of non-adherence, and finally graft loss because the whole family situation, because of the drug addiction, is so chaotic. There is very little hope of timely improvement through counseling of the parents, and also the parents will not cooperate in any way with taking away the parental authority through the courts and seeking a foster home for the child. So what is the outcome of this? The team really wanted to go ahead with the transplant, but they had to find a solution for this high risk of non-adherence. And what came up in the end, that was the sister of the mother of the boy. She had a family of about the same age children, and she volunteered to take the child as a sort of a foster child, and we made an agreement, even a financial and a legal agreement, that she would look after the child after the transplantation for 5 years, and all the social care and the financial aspects of that were transferred to that sister. So the boy would grow up in a normal family situation, and the non-adherence risk was absolutely reduced because the sister was able to take it over. And this prevented, let's say, the awkward situation where there should have been a foster home for that child in a situation that was absolutely not, let's say, positive for adherence. Okay, a second case. This involved a teenage mother with 16 years old who was in a hopeless conflict with her parents, and she lived in a shelter. The baby was diagnosed with biliary atresia, needing a quite urgent liver transplant. There was no suitable donor liver available at short notice, and the parents of that girl absolutely refused to become living liver donors. So the mother, the 16-year-old, said, I will become the living donor for this baby of mine. And should she be accepted as a living donor because she is a minor? And the considerations here was that there is especially in the country where this happened, a legal criterion for allowing living donation of 18 years. Exceptions only in the case of regenerative organs or tissues. And also on minors, the decision on medical treatment, it must be in accordance with the patient. So you have a legal problem there as well. And the parents, as I said, were in hopeless conflict. So in the end, what was the solution here is that we took the case to the court, to the family court, and said, well, two things. The girl is absolutely competent, mentally competent to oversee the consequences of becoming a living donor. And also, you could say that the liver is a more or less regenerative organ, and so will not create, let's say, a lot of harm to both the donor. So the court decided that the transplant could go through, and she was the girl became the living donor just before she became 17 years old. This is a very tough case, a sad case, I must say. A teen with suicidal history, a boy of 14 years old. He was admitted to the clinic with a drug overdose, leading to acute liver failure. And there were already suspicions of suicidal intentions of this situation. And he has a history of psychiatric disorder, schizophrenia perhaps, and already a history of repeated suicidal attempts. So should he get an urgent liver transplant? Again, some facts. There are no uniform guidelines for transplanting patients with pre-existing psychotic disorders. Some treated as relative, others as an absolute contraindication. But the general opinion I found out was that to exclude the patient on the basis of psychiatric diagnosis alone is unjust, just like the cognitive impairment. But on the other hand, there is experience that active psychiatric disorder is associated with a high risk of medical non-compliance, makes sense, and also that previous suicide attempts is a strong factor for predicting future suicidal attempts. And this is in fact what happened. The boy was transplanted as soon as possible, and they started an intensive counseling, psychiatric treatment. But after 6 months after the transplant, he attempted suicide again, and this time fatally, and with an functioning graft. So you could say it was a very sad outcome for the team. Well, this looks very much like the presentation of Professor Rees, and I'll go quickly through it. Again, a girl with a complex congenital defect causing severe cognitive impairment and progressive renal failure. And the parents wanted her listed for a preemptive, if possible, kidney transplant. But the transplant center in the country where they lived refused because of the severeness of the mental impairment. It was a European center, not an American center. In this case, it looks like American center. But they feared that the transplant itself would harm the girl in her, let's say, life, because it was clear that the life expectancy of this girl was quite short. So the parents came to a center in the Netherlands for a second opinion what to do. And as Professor Riesel said, he said there are no uniform guidelines for cases of cognitive impairment. Indeed, in 1995, the American Society of Transplant Physicians said cognitive impairment can be considered a contraindication, but only if it's so severe that there is no possibility of having a good compliance and no one can, let's say, compensate for that. But I think today most centers will conform to what it was said in the Harvard Boston Ethics Committee, that pediatric patients with cognitive impairment should not be categorically excluded from transplantation because there is no evidence that the outcome is different. Oh, sorry. So what happened here is quite extraordinary. That the center, the Dutch center where the parents came to for a second opinion said, okay, we can do the transplant, but how shall we do this? So the mother volunteered to be a living kidney donor, but it came out that she was not suitable, also because of size match. And then, very interestingly, an altruistic donor stepped forward, and she became the donor for this child. And the mother of that child with cognitive impairment then donated her kidney to the list. So, as a sort of compensation for that, because they could not be involved in a paired kidney donation, there was no situation, but she went to the list. Okay, the final case that I want to present to you is a family that was caught up in a political debate. There was a mother and 2 children from Armenia, and they applied for asylum. And after a lengthy procedure, their status as refugees was denied, and all their legal options were exhausted. The boy of 7 years had already end-stage renal disease and had already started dialysis in the country where they were temporarily staying. Because of the strict rules, the mother is deported back to Armenia, but the children were allowed to stay temporarily, awaiting a final decision, because in that country we have a child pardon under certain conditions. But it was a very precarious situation. The children could be deported also, and they were seeking shelter in a church. The dialysis treatment was severely compromised in that situation, and an early kidney transplant is to be preferred. So the center where the child was under dialysis said, well, what can we do in this situation? So their opposing, let's say, arguments On the one hand, Armenia is considered a safe country, so they have no right to asylum under the normal rules. A child pardon is only granted to children who have stayed in the new country for more than 10 years, or are born there, and are totally rooted in that new culture. And this was not the case for these children. On the other hand, there is a universal right to family, as it's called, so there should be no separation between the parents and the child. And the center also said, well, if we transplant the child, it could be considered as a final solution, and he can be sent back to Armenia, so what to do? On the other hand, the availability of dialysis and transplant care, also from a financial point of view, in Armenia was very bleak for this family. So in the end, the center decided to transplant the child, and very soon after, both the children got a pardon. They got a refugee status in the country, and even the mother was brought back to the country because of the right of family. So a happy outcome, you could say, but there is by no means a real solution, because it depended totally on the Minister of Foreign Affairs to exercise his discretion in these cases. So I think I've given you some thoughts to, and Joe, to reflect on this, and so thank you for your attention, and we'll see what Joe comes up with. So okay.
Thank you, Mike.
My simple statement is look at all the possibilities and get transplant done if you can solve the problems. Okay.
Okay, thanks. Mike. Things in Armenia are improving, so hello to the people in Yerevan who are watching. We have a program with them through the Transplantation Society to try and get their transplant programs going. It gives me great pleasure to introduce Joe, who's an intensivist at Great Ormond Street, but also has not just a national but an international role in the ethics of transplantation and organ donation. And now we're going to hear his take on this.
Great, thanks. Thanks to the organisers again. I have to say, coming and following Mike and Leslie, who are two of the nicest people in medicine, I'm amazed I wasn't booed to the stage, but I'll see if I can be booed off the stage. The topic we were given, children with limited life expectancy should be offered transplantation. Well, obviously, I don't know why you would do a transplant otherwise. But, you know, we have to think about whether we're doing the right thing for the child. And I'm going to push you very hard. Meet Boris. Too soon? Election? Purdah? Not sure. Boris has been born with no brain. He has a condition called anencephaly. His parents do not want him to be discriminated against and afford to manage to get him to a unit in Italy who've commenced long-term ventilation via tracheostomy. It is a fictitious case for those of you starting to twitch. Boris is now 1 year old, being kept alive on a ventilator. He hasn't met any developmental milestones, how can he? And he started to develop renal failure due to free reflux. Living donation is against parents' religious beliefs. They want Boris to go on the deceased donor list. I did say I'd go hard, Leslie. I think the debate we're talking about is about the old-fashioned ethical idea that sanctity of life and quality of life are somehow opposed to each other. Sanctity of life, the idea that human life is sacred, argued mainly by pro-life side in political and moral controversies. You know the controversies. It's very anthropocentric, the idea that the human form is much superior and we do lots of things to keep human beings alive. Some Eastern philosophies actually argue that other species should be included as well. What about androids or aliens? You can see I'm going outside my remit. But when does this apply? Is it at the beginning of life, conception, the quickening, fetal life? And the other argument at the end of life, when does it stop applying to you in terms of when someone has severe dementia or is brain dead on a ventilator? The point about that is, though, the sanctity of life, no organisation, no religious group thinks this is absolutely the standard law for everybody. Otherwise, everyone would be on a ventilator when they died. You would never stop things. So it's not a right to life. There's no right to keep someone alive. So a right to life, but not a right to be alive. So let's pull back to the patients we're talking about here. If we're doing a renal transplant here because the alternative is somebody dies, then you have to think about the bare stuff that's going on. So if you're alive, you exist. You have a benefit as an individual in continuing existence. Then concepts of the quality of life, how good someone's life is. Leslie's talked about some of the stuff there about how you may think about that. But most of the objective scores people talk about are terrible. It's really hard to stand here and say what someone else's quality of life is. This is a subjective measure. You are the best judge of your quality of life. But if you're a children with complex learning problems or disability, it's very hard for you to express what you think about things. The opposite is if you're dead, depending on your views, you're either in oblivion, you fail to exist as an entity, or you're in paradise with God. You may argue that children don't tend to go to the other place. So 5 points and a free coffee for where this is from. William Blake from Dante's Inferno. Satan there in the middle of his life. So quality of life, I think it's really hard. It's very subjective. The scores we have when medical teams look at them and go and talk with adults with learning difficulties, you can have a conversation. Adults with disabilities and learning difficulties score their quality of life much higher than clinicians, physicians, doctors, nurses. And for kids, it just is a horrendous idea to have that idea. Our current European overlords measure quality of life this way. Again, I don't think this is particularly helpful. Really hard. Too much politics. We've got an election on next week, guys. In adults, we'd be having this discussion talking about euthanasia, assisted suicide, assisted dying, law, ethics, and religion. In children, in most countries, although Mike, of course, from Holland, where you have euthanasia for children, just to highlight that, we don't have that here. But our concepts of what we do here are much more about when we might withdraw or withhold life-sustaining treatment. And the argument I'll make is that a renal transplant, in this sort of concept, is a life-sustaining measure. We're much more focused on plans around end-of-life care, thinking about the individual and the families, and not limits of care, but withholding, withdrawing life-sustaining treatment. For us, with an international audience, where do our standards come from, our moral norms? I'm going to appeal first to law. The overarching law most countries, all but one really, would have is the UN Convention on the Rights of the Child. No time to go through it in length, but this should be on every wall of every children's hospital. A child version of the UN Convention. And from that, in the UK, our own law comes from the UN Convention into the Children Act in the UK, and the term Leslie used, and again, this is the judge in the case, the Guard case recently, children's best interests are paramount. Paramount meaning the most important thing, not just a consideration, but the number one consideration when you're making decisions for children. Paramount. How do you work out best interest, though? It's kind of tough. The idea comes from the welfare standards from US law originally, where you're working out almost a table of burdens and benefits. This is really important. So not just burdens, but the child's ability to benefit from your intervention. Wishes, feelings, physical, emotional, education requirements, a lot of this stuff, and again, Leslie's argument might be, it's really hard to work this out for a child with the most severe end of learning difficulties. But how can we work that out for Boris with his situation? Not easy. So we default to the parents' viewpoint, don't we? And this is an idea from Lynn Gillam in Melbourne, the idea that we normally work with a zone of parental discretion. Every day in your hospitals, you sit around with the parents of children and you talk about the right thing to do. And as the child gets older, that's expressed more and more by the child. There'll be different laws in different countries about when the child can make decisions, but the child's best interest is determined in this zone of parental discretion. And either side of this, there are things that parents either are not allowed to refuse for their child. So if a child came in now with a massive subdural hematoma and was dying, and the parents said, do not do an operation, we would do it. Parents do not have control over us trying to save their child's life. We don't have time to go to court. You save the child's life. The other end, there are parents, things that parents cannot demand for their children. So has anyone got a teenage daughter here? Do you know what age you're allowed to have a tattoo? Or she's allowed to get a tattoo? 16? Never. Never is the right answer, because you're the father going, not happening. Never. A child cannot have a tattoo. It's against the law in this country. Maybe different in different countries. So you can't have a parent going, oh, for your 14th birthday, you can have a tattoo of a butterfly. No, not allowed. Being a bit silly. But the problem with this is, when you talk about the debates and some of the issues and the controversial cases here, here's one of the first ones. Some parents in Southampton didn't want to have the recommended international radiotherapy for their child. They wanted something different. This was really controversial at the time. Some of the voices from here, between the ICU nurses looking after very sick children, thinking, well, parents just dictate and tell us what to do. It's a real feeling for that at the moment in the current ICU world. But the other side is when you have parents of a child with complex problems, including learning difficulties, they're more and more feeling that people are having to listen to them. And that balance has shifted, almost certainly for the better recently. So here's my number one rule as a UK doctor. The General Medical Council, rule number one, make the care of your patient your first concern. When I was doing adult medicine, it was really obvious to me who my patient was. It's the bloke in the bed. I don't know if I've got a light on this, probably not. On the right, who's my patient? Is it the child in the bed? Is it the parents and the child? I think in pediatrics, we often talk about the family with family-centered care. There's a couple of references papers there for you. I've even published on it. So the idea that most pediatric treatment is much better when we look after the family as the unit. But I will argue just occasionally that compromises the child. Just occasionally. So withholding, withdrawing life-saving treatments or decisions to limit therapy, two different acronyms for it there, comes on this basis that actually children aren't supposed to die. In society, in culture, this seems the way the world is now. The death of a child is just abnormal. When it does happen, most deaths, I don't want to worry you, you're all going to die, hopefully not this morning, but most of your deaths, most people's deaths, have some medical decision-making involved with them, whether that's a DNR, a decision not to go into hospital at the end of life, a decision not to go to the ICU, a decision not to do something, or to stop something. So even on the ICU, most deaths, around 2/3, have a decision about either withholding or withdrawing life-sustaining treatment. So the idea from many religious backgrounds that death is only for God to determine, I may be right, but there are medical decisions being made about most deaths. We fool ourselves if we don't believe that. So the allowed natural death stuff comes from that sort of background. Into this, our UK Royal College, as part of the group, have a document that is very, I think, up to date, been looked at recently and decided still fit for purpose, where we work with children and their families, normally to work out when it's right to stop life-sustaining treatment or to not start it. The last version, there's an awful lot more palliative care, child-centered, even in the ICU, thinking about how to care for the holistic part of children's lives going forward. Organ donation, now routine and end-of-life care in childhood, which I'm sure you're very keen on. The 5 categories when life might be limited in quantity or quality in children who are old enough and able to competently decide things are there. But I want to highlight the axioms here. This is based on timely, open communication with mutual respect in there between clinicians and family. And I think we've not got that right over many years. That's our side. Mutual respect for children and their families in a really tough space, making the hardest decisions. So Leslie highlighted some disputes occasionally happen, might be between parents, between, who would say this, renal transplant surgeons and nephrologists. Apparently it happens. I'm amazed. Is that right? Never happened, not where you work. Simply resolving disputes is a listening exercise. Multiple MDTs, but particularly with the families, whether they have a faith-based issue, community-based, whatever it is, bring people in. Mediation, ethics committees, community teams, second opinions. If we get questions afterwards, we can talk about this. But 99% of initial disputes are resolved. So most times, sitting with families, whatever the problem is, however difficult the situation is, this is resolvable. Some thoughts about what's happening here. When I were a lad, we do have more cases going to the courts as a nation. Still tiny numbers, but at 20 in 2018 versus 6 in 2008, and the processes are taking longer. And I think this is not based necessarily on our side of this, but the differences in society, populism, pluralism, contempt for experts, and the social media aspects are very important. We might come back to that when we look at how that happens at transplant. But one of the issues is that death, I mentioned before, is hidden away in society. So those of us old enough to remember the 1900s, 1 in 7 children died in infancy. By 72, that's 1 in 600. That's even less now. Even in our ICU world, death is really rare now. We have a mortality of 3% in the sickest children in the ICU population. But that's not necessarily because we're much better at our jobs, which of course we are. Can I go with that? It's because we're making different decisions on the same stuff. We are keeping children alive who would not have been kept alive in 2005 and 6, 2011 and 12, because stopping the ventilator is now not allowed. That's really important. Many more children are coming out to the ICUs with complex health care, ongoing needs. Prematurity, you know that's a massive success. Congenital heart disease, massive success. The proportion of children with ongoing health needs who either have a serious brain issue, serious lung issues, has not changed. So with many more survivors, we have many more children with complex health needs. Here's the number of kids in England and Wales, 2012, it's pretty unchanged, with life-limiting conditions in our community. It's going up for all the possible diagnosis, and I hope the urologists note that genitourinary is on there as well. The problem with this is not spread across our society. There is a huge preponderance in people who are poorer, from cultural groups who cannot access healthcare. Again, that's on us. We have not interfaced well enough with demographic changes with people who are not used to interfacing with modern healthcare. The other thing we're doing, we have death deferment devices on every street now. Every street's got a kid on a ventilator. Community PICU, home ventilation, home PN, home renal replacement therapy for children who will never get a transplant, home ventricular assist devices. We're doing more and more stuff. Last year, we referred a child for palliative home LTV and parental nutrition, same as Mike's case, didn't have a home. The social stuff, you can't ignore that and say that's someone else's problem. That's part of the factors here. Long-term ventilation is going up exponentially. But here's the last bit. This is the important bit. The campaigns between these two polarized groups, the religious right-wing groups from the US came over with the Evans stuff recently in our country, versus Gandhi's quote. So huge amounts of US healthcare particularly are spent on the last year of life. And he's arguing against that in his book, Being Mortal Medicine, What Matters in the End. Death is the enemy. This is the feeling there. People are fighting death all the time. And that's a much worse way to look after people, particularly sick children, than if you accept where things might not be likely to work. If we just fight death, that's really bad. So just to finish off, doing things to versus for a child is illegal. Who's this happy man? Any Germans here? Can't. Thank you. I thought you'd know. Categorical imperative. Never treat a human being as only a means to an end. A very important rule. Even if that end is parental preference. Parents don't own their children. We have considerations of best interests and welfare. Rights, responsibilities of parents are exercised in the child's best interests. The state has interest in child welfare. Sanctity and quality of life are very, very important. We normally resolve most disputes, but sometimes children are better if they are allowed to die. Hard statement, but it is true. So Boris, back to Boris, how can he die? He's got brain failure. He's got respiratory failure, he can't breathe. He's now got renal failure, and it appears he can't die from that either. Intercardiac infection, well, he can't die from that. What do we do? Where's the burdens, benefits for this kid? And the last thing to finish off, just because I know you want me to go there, but I'm not brave enough to do it. What about the opportunity cost to other children? Who doesn't get the organ transplant? Who doesn't get the ICU bed? What about the children in Armenia, wherever it is, who are getting less health care than kids in this country? Do we even think about children in sub-Saharan Africa, or is that going too hard on you? Where do we limit the children we're considering? And the magic money tree for healthcare funding? Last I saw, there were some things people are having restricted to them that can clearly benefit them. There may be ladies who've got breast cancer and are not getting chemotherapy in this country because we can't afford it. That's uncomfortable, isn't it? So where do we stop? And I would argue that if we discriminate against Boris, who's got probably the worst learning impairments you can possibly have, aren't we just being discriminatory against children with learning difficulties? Ooh, that's a bit hard, isn't it? I'm done.
Thank you, Joe. Okay, so we've got a few minutes now for people to tell us what you think about some of those difficult decisions and difficult concepts. Who would like to kick off?
I think they all agree with me, it's fine.
Yeah.
Thank you for the very interesting talks. I mean, the difficulty is that you're never going to get big enough numbers to have a precedence or be able to have an absolute guide on what you're going to do, and they're going to be case-by-case basis. And I think the big thing, particularly in renal transplant, is the availability of a live donor. I think personally that is a game changer with regards to the discussion. But I mean, I know the example with Boris, but it's quite an extreme because it's a fictional case. I think, yeah, and I think. You know, I've personally come across a couple of cases where we've had disputes in our own centre, but fundamentally they have to be looked at case by case and just having an extended MDT discussion.
Thanks very much. Very interesting talks. It's interesting to hear both of you talk about utilitarian principles, which I don't think of as being generally applied to the paediatric population. I think when you look at the adult community, particularly the renal transplantation, that can be quite illustrative. We're pretty liberal with adults with limited life expectancy that we put on the list. You know, people in the late 70s get onto the adult kidney transplant list, and we don't have problems with that. And I guess when you talk about the GMC duties of a doctor with making your patient your first concern, whether really utilitarian ethics in such a large country or global population really perhaps don't have any bearing on our paediatric ethical considerations.
I had to play up to being an intensivist. It's fun. The way we would resolve any dispute is to sit down with the child and the family. We have a meeting with the teams, not just an MDT, we have an ethics group who work with children and their families with previous parents. So I'm playing up a little bit. I have to say the utilitarian stuff, we've gone so far against it now that I think we're coming full round to go, well, actually, if we lose it entirely, we will be in trouble quite soon when the next pandemic hits, because we'll be left with no frame of dealing with true overwhelming need based on a population out there where death rates are massively high because of a sudden infection. But I would reserve ethical thinking almost for that type of area to use utilitarian principles, if that makes sense. Everything else is much more for us based on the child's best interests and welfare. When you stick in front of the courts, they don't say anything about utilitarian principles. It's all about that child in front of you. I think the utilitarian bit on the GMC is down number 6. Use resources wisely.
Oh, this is a great discussion. I think that first of all, I just want to address some of the things in the sense that we as physicians, we have to take responsibility of this. If you know that the encephalic case, I know it's extreme and everything, you know that it's not going to have an outcome. It's our responsibility to provide the clarity. This is why we're not going to do it. Parents do not want to have that responsibility. I can assure you that. They don't want to say, I'm going to take the life out of my child. It's our responsibility to create an organized plan for that child. Now, let's say it's so controversial. There's a few blessings in Northern California, even though we're in California, is that we have 3 transplant centers in which you have a problem, you can get a second opinion or counsel from other institutions that family can go and feel sure that what you're doing at least have some backup. And third is, in our center, we have very intense palliative care work in all these cases in which at least provides a platform for very open discussions about end of life.
Thanks, Valo. Just picking up on that last point, on the adult side, and a couple of you mentioned palliative care or conservative pathways becoming an increasingly important aspect of treating renal disease. And we're either not putting people on dialysis or withdrawing them from dialysis. And it's still in its infancy, it seems to me, in the pediatric world. Let me ask the audience, how many of you, show of hands, how many of you think we overtreat children with renal failure, either with dialysis or transplantation, that we're doing too much, we shouldn't be treating quite as many children as we are?
Can I just clarify, you're asking a room full of renal transplant. Do you want a job? This might be Turkey's voting for Christmas moment.
Does anyone think we're dialysing too many children? No? Okay, I'll put my hand up. Francis, do you want to comment?
No, not really. I mean, each case is what are you trying to get out of the scenario that you're presented with. Survival isn't the only thing.
I think, to my mind, the issue is when you're 80, someone says, "Well, look, do you really want dialysis? Would you rather go home and die quietly in your own room with your family around you?" When you're 1 day old, it's much, much harder to have those conversations with the parents.
I think there are excellent comments that have come up. In the International Pediatric Transplant Association, we discussed producing, guidelines, and I think one of the first things is we have to look at the world resources. So you could turn around and say the 20% who don't have access to dialysis and transplant that actually have a normal life that could actually have, if you're going to say, a better quality life than somebody with severe learning difficulties, needs to be looked at. But also nationally, the British Association for Paediatric Nephrology, we've considered having an ethics committee, but my strong view is you need to see the child. So actually having a room full of people where somebody's got a loud voice, but they've actually never met the child, and in fact you could then question it and say, well, who are we to make the decision? Because we see, okay, maybe Leslie has seen this patient over the last 9 years every single week, but look at the cumulative amount of time that patient has been in the home, in the school, in the community. And actually, can we come up with a snapshot decision? And I agree that inevitably what we do is we try and resolve the issues with the parents in what we deem to be in the patient's best interests. But I was going to comment, Nizam, as well, you're talking about adults, that I was really blown away by the one big centre in the United Kingdom who showed adults with severe learning difficulties that were living in social care homes, where the people from the care homes went to the committee to say, we don't think these adults should be transplanted. And the centre, against the people who are looking after them, decided that they should actually proceed to transplantation. So we're talking about, do we look at what the parents think, and in adults who don't have that backup, do we? So I think it's a really, it's opening a minefield to actually know what's the best thing to do. But I still think we need to think what's in the child's best interest and try and come to an agreement.
Yeah. I just want to reflect on what Joe said about death being the enemy. In the Netherlands, we have, since a couple of years, a very interesting debate, especially in intensive neonatal care, not looking at, let's say, the situation, should the child live, but is there a situation where you should let the child die? So reverse the debate and say, of course, life is the situation that we find normal, but under any circumstance, is there a possibility that you could say the best interest for this child is not to live? And I don't know if you're familiar with the development of it. It's called the Groningen Protocol. And there they reversed the debate and said, from a medical point of view, we cannot see any, let's say, benefit for this child. So going on with the treatment is not in his best interest. But we have to explain that to the parents who naturally have the opposite view. And it's very illuminating to see these debates, how in the end the parents will accept it, and not only accept it, but also understand why the medical team says it. I think it's very it's an exercise that you should do, not say, why should he live, but is there a possibility where he shouldn't live?
Very good point.
I think, according to the Netherlands, we have even a more previous possibility in the treatment, is that according to overtreatment with dialysis, what was your question, all the pregnant women have the ultrasound at 20 weeks. So I think in the Netherlands there are many children who are aborted very early because you see that there is a very severe renal disease, for example, when there's oligo or anhydramnion, or so we don't see many neonates anymore because of a phase which is even earlier than the neonate who is alive.
Any other thoughts?
Mike, I just wanted to ask you about that case you presented about the 16-year-old who donated a lobe of her liver. Do you think the outcome would have been different if it had been a kidney and there was you couldn't claim the regeneration bit of the argument?
Yeah, oh, sorry. I think the debate would have been very much the same, because the fact that the liver more or less is a regenerative organ was not the decisive argument. The decisive argument was that the girl was deemed to be competent. I think in the UK you have the Gillick competency, which is the outcome of a court case, which says that in this case the person, the minor, is competent enough to oversee the situation and, let's say, accept all the consequences. So I think it would have been the same outcome for a kidney.
Because, I mean, in my view, I think nothing makes you grow up quicker, I imagine, than having a child. So if a child, a teenager has a child of their own, it's completely natural and normal for them to want to help their own child.
In the California law, when a teenager has a child, that becomes an issue of emancipation. So they can make decisions on their own health care. This person is already 16, she's a mother, she has a right to be emancipated to make decisions for her child and herself.
Yeah.
So it's not Gillick, just to clarify for the English people in Welsh, it's not Gillick for over 16s, so Family Law Reform Act, the same. So a 16-year-old has a presumed right to consent to medical treatment, but it's meant to be in their best interest, and that's the question. Is this her interest, the child's interest? I think we would make an argument it is, but it's a little bit more of a further thing than a right to consent.
The pregnancy makes a difference.
I understand. I'm saying we're a little bit short of that.
It's the pregnancy.
Yeah.
Okay, I think what I'm going to do is wrap this up now because we're a little bit behind. I did promise summing up from each of you, but unless you feel strongly that you want to do that, we'll
I agree with Mike.
Okay. We'll continue the discussion over lunch.